Good morning. In the capacity of the President of Indian Society of Gastroenterology, it is my pleasure to welcome you to Masterclass Series 6. In fact, Indian Society of Gastroenterology has been conducting masterclasses very regularly, particularly to benefit the postgraduates such as DM and TNP students. And these master classes were taken by the experts and they have been very beneficial. In fact, each of these master classes was uploaded to the YouTube channel of ISG and they are very popular among students. And we are happy to start the next series of masterclass. We are starting with first series or the first session, that is chronic diarrhea. And subsequently, every month, we'll continue to hold these master classes. I'm sure that these master classes delivered by the expert will benefit the students and the physicians and gastroenterologists in the country, as well as the adjoining countries. I wish these master classes a great success. I'll now hand over to Dr. Matthew Philip, Secretary General of Indian Society of Gastroenterology, to continue with it.
Thank you, Professor Ghoshal. Good morning to everyone. I bring in greetings from Indian Society of Gastroenterology, and it gives me immense pleasure to welcome you all to the 6th series, first session of IST Masterclass, which is a quite popular one. Now we are resuming this year's new online platform. We are privileged to have Professor B.S. Ramakrishna with us today, and the session will focus on a very important topic of advances in chronic diarrhea. And now I hand over the session to our esteemed moderators, Professor Govind Makharia, who is the Professor of Gastroenterology at All India Institute of Medical Science, New Delhi, and Professor Vinod Dixit, Professor of Gastroenterology at Banaras Hindu University at Varanasi, who will take it forward and introduce the speaker and the subject. A quick housekeeping note, please keep your microphones muted unless speaking. We also encourage you to post your questions in the chat box, which will be taken up during the question and answer sessions. And this is going to be a very interesting session. Please listen and glued to the computer throughout. And over to you, Professor, now. Wish you all the success. Thank you. Professor Makharia and Dr. Dixit, start the proceedings now.
Okay, so now before I request actually Dr. Makharia to tell about the topic, which is very important to all of us actually, I have a privilege to introduce Dr. B.S. Ramakrishnan. I had a pleasure actually meeting him when I was DM student and I visited to CMC Vellore. All through actually he has been working on the small bowel diarrhea, and I know many of the publication actually which are really just a very good and is important actually for all of us. He retired as a professor head from the CMC Vellore at the Department of Gastroenterology, and then he came and he joined the Chennai SIMS Hospital, where he's working as a head of department of B.S. Ramakrishna. So it's my pleasure, but because many more things to be done, but because the paucity of time, I stick myself and I request Dr. B.S. Ramakrishna to cover the topic called chronic diarrhea, algorithmic approach and neuroinvestigation. But before that, I will request Dr. Makharia to tell us about the topic, importance of the topic to our audience. Dr. Makharia,
good morning, Dr. Dixit, Dr. Gosal, Dr. Matthew Philip, for this wonderful initiative. I think Masterclass have been one of the most highlight program of Indian Society of Gastroenterology. Just to cover a topic on chronic diarrhea, we all know that about 10% of global population have chronic diarrhea. And of that, majority are functional, almost 80%, and 20% are organic, which also both include small intestinal disorders and large intestinal disorders. And in our routine clinical work, I think all of us will see patients with chronic diarrhea. As diarrhea occurs from both small and large intestine, and there are numerous causes of it. Therefore, it's imperative that we approach these patients in a more defined and algorithmic manner. And that's our topic today. And who better than Dr. Ramakrishna? I think always taught the whole country about approach to chronic diarrhea. To speak to us today, Dr. Ramakrishna, please. And also, just before he starts, as Dr. Matthews said, please write your question on chat box, and we'll make sure that we respond to most questions which come in chat box. And let's go ahead, Dr. Ramakrishna.
Thank you very much, Dr. Govind. Thank you, Dr. Dixit. Thank you, Dr. Matthew Philip, and thank you, Dr. Ghoshal, for this opportunity to talk about chronic diarrhea, which is a significant problem affecting that we get referred to us gastroenterologists very frequently. So I'm really going to talk about an algorithmic approach. This is what I was asked to do. If I may be allowed to share my screen, I am not able to do that right now. Okay. So during the course of this talk, and I'm going to kind of break it up in between. We'll have a little bit of maybe a poll and then some questions from all of you, which we will address, and then we'll go back to the second half of the talk. So basically, I'll be talking about a very practical approach, and I talk about what some of the societies advise in terms of proceeding with investigation. So what is chronic diarrhea? We can define diarrhea as increased stool volume, increased fluidity, or increased frequency of stool lasting longer than 4 weeks. And this would be chronic diarrhea. Now, as Dr. Govind mentioned, chronic diarrhea can be functional, by which we mean that there is an alteration in the function of all of it is actually alteration in the function of the intestine. But functional essentially means that there is no structural damage that we see. And we have organic causes where there is actually a structural problem. So the organic diarrhea can be caused by several things. It can be due to increased fluid secretion, which is called secretory diarrhea. It can be due to malabsorption, which is malabsorptive diarrhea. It can be due to inflammation, or it can be due to rapid transit. Now, to the residents, the students in this talk, I would emphasize that you must all take a very good history. Now, history is all important. In fact, in most of these patients, you can make a diagnosis by taking a good history and looking at the patient without actually even putting a hand on the patient. And very often your diagnosis will turn out to be correct. So the stool characteristics are very important. So ask about frequency, find out if there is diurnal versus nocturnal diarrhea. Does diarrhea wake the patient up from sleep? The consistency of the stool. So in terms of irritable bowel syndrome, we are very used to the Bristol stool form scale. But in organic kinds of diarrhea, the regular questions about consistency are better. The color of the stool, the presence of air, gas in the stool, presence of oil in the stool, which is distinctive, happens in pancreatic exocrine insufficiency, and the presence of blood or mucus in the stool. So when we classify chronic diarrhea, we can label it as functional, where the pathophysiology is altered motility or secretion, or it can be organic. And organic, as you said, so here are some of the conditions listed. Functional diarrhea can be diarrhea predominant IBS or functional diarrhea. And organic diarrhea, secretory diarrheas are due to endocrine tumors, can be due to bile acid diarrhea. Malabsorption happens in small bowel mucosal disease, and I'll focus on this a little bit more, or pancreatic exocrine insufficiency, about which I'm not actually going to spend a lot of time. Inflammatory diarrhea can be inflammatory bowel disease, can be tuberculosis, can be microscopic colitis. Rapid transit happens with hypothyroidism and drugs. And then there are other unclassified things which can be factitious diarrhea and spurious diarrhea. So how to differentiate functional from organic? Is the problem long-standing? Are there periods of constipation alternating with diarrhea? Does diarrhea wake the patient up at night? Is there significant weight loss? Is there blood in the stool? So based on this, you can look at functional versus organic. Generally, functional diarrhea is more than 6 months. The Rome criteria emphasizes duration of at least 6 months. Organic is generally shorter than this if they come to attention quickly. Weight loss more than 5 kilograms should suggest organic cause of diarrhea. Stool character, usually with functional diarrhea, it's small caliber stool of variable consistency. Nocturnal diarrhea is absent generally in functional diarrhea, although it does occur in some. Mucus is often present in functional diarrhea. Blood is absent, and there may be interspersed periods of constipation if it is functional diarrhea. So we talked about the types of diarrhea: secretory, malabsorption, inflammatory, and rapid transit. So secretory diarrhea is generally watery. If the diarrhea is watery, consider conditions like hormone-secreting tumors of the pancreas, microscopic colitis or collagenous enteritis, drug-induced diarrhea, excessive intake of sorbitol and osmotic agent. At one point of time, chewing gum with sorbitol is in Western countries, it's a cause of chronic diarrhea. And then there's factitious diarrhea where the person actually doesn't have diarrhea but makes up diarrhea by adding water to the stool. Is the diarrhea steatorrhea? If it is fatty diarrhea, so if it is pale, bulky, frothy, foul-smelling, and floats in the pan, which is how it's typically described, then consider malabsorption due to small intestinal mucosal disease, pancreatic endocrine insufficiency, and sometimes drug-induced diarrhea or surgery, gastrointestinal surgery causing steatorrhea. And this happens particularly with conditions like bariatric surgery. If there's blood and or pus in the stool, then consider inflammatory diarrhea, which is ulcerative colitis, some forms of infective colitis, drug-induced diarrhea, and GI polyposis syndrome. And of course, Crohn's disease would come into this, but it'll be part of the inflammatory diarrhea without macroscopic blood in the stool. Another very important question to ask is there pain, abdominal pain? So the presence of pain indicates inflammation, ulceration, or partial bowel obstruction. So for instance, you will not expect a person with, say, tropical sprue to have abdominal pain because there is no overt ulceration, there's no partial bowel obstruction. On the other hand, somebody with abdominal tuberculosis is likely to have abdominal pain. The location of the pain can tell you something about the site of the disease. So if the pain is around the umbilicus, generally you say small bowel disease. When you say small bowel disease, so pain, it can actually indicate periumbilical pain, can indicate even ileal disease and right colonic disease, because that's where the midgut ends. If the pain is in both iliac fossae, it generally indicates large bowel disease. Then inquire about other symptoms. Abdominal pain, I said it's inflammation or stricture. Bloating or abdominal distension or borborygmy usually indicates carbohydrate malabsorption. Now, just bloating alone and borborygmy, you're all familiar with the fact that varieties of carbohydrate malabsorption, sugar malabsorption, etc., can cause that. But even in conditions like tropical sprue, the bloating of the abdomen, distension of the abdomen, visible distension is due to carbohydrate malabsorption. Weight loss is due to inflammation or energy malabsorption. Tiredness and weakness can indicate mineral and vitamin deficiency and anemia. Bone pain will indicate calcium malabsorption, osteoporosis, osteopenia. Night blindness, vitamin A malabsorption. Amenorrhea and infertility will indicate secondary hypopituitarism. And these can be sometimes just the presenting features of celiac disease. Muscle wasting, look for that. Temporal hollowing indicates muscle wasting. There may also be peripheral muscle wasting. Loss of buccal fat, edema, leukonychia, skin manifestations which indicate deficiency of zinc, which are usually around the mouth and around the anal orifice. Vitamin A deficiency, essential fatty acid deficiency. Look for glossitis and chelosis and anemia. PTK, easy bruising, dehydration and hypotension, the presence of tetany, corneal xerosis, beetroot spots. And in the system review in patients with chronic diarrhea, look to see if there's a goiter, look to see if the liver is enlarged. Liver may be enlarged, maybe just due to fatty liver in somebody with severe malabsorption. Sometimes the liver is enlarged because of tumor in the liver, like carcinoid syndrome, which causes diarrhea, is usually due to liver metastasis by neuroendocrine tumors. Look for cardiac murmurs, again happens in carcinoid. So then we proceed to investigation. So having done these initial tests, you start with some simple tests. Always in a patient with chronic diarrhea, start with the basic tests, complete blood counts. Look at the presence of microcytosis. MCV is very important. If there's microcytosis, it tells you there's iron deficiency, which may be malabsorption, or it can be due to ulcers. If there's macrocytosis, it tells you that there is either folate or B12 malabsorption. There's thrombocytosis, it generally indicates inflammation. And in that case, think of inflammatory bowel disease. ESR and CRP indicate inflammation. I find the liver function test always very useful. Look at albumin. That again tells you that the person is losing. If it's low, tells you the person is losing protein or is malabsorbing protein. Look at the globulins. So if the globulins are high, then think about conditions like immunoproliferative small intestinal disease or some kind of the severe where the globulins, even chronic liver disease would give you hyperglobulinemia. If the globulins are low, again look at that because that's a very important clue. It tells you that this person may have hypogammaglobulinemia. Elevated alkaline phosphatase, again, if it is ALP is elevated without increase in gamma GT, then consider an intestinal alkaline phosphatase being elevated. And this can happen in immunoproliferative small intestinal disease. If both ALP and gamma GT are elevated, then it's possibly due to fatty liver secondary to malabsorption. And then it's good to look at both the monovalent and the divalent ions, sodium, potassium, bicarbonate, calcium, magnesium, because these indicate chronic disorders, they indicate epithelial involvement. So you cannot brush it off as a functional diarrhea. Now, HIV, depending on the context, it needs to be done. And then we get tests like iron, folate, and B12. Now, do remember that iron and folate are absorbed primarily from the duodenum and proximal jejunum. B12 is primarily absorbed from the terminal ileum. So in celiac disease, for instance, you will find iron and folate deficiency fairly commonly. B12 deficiency is uncommon. The reverse is true in tropical screw where B12 deficiency is common. And iron and folate deficiency may occur, but that's not predominant. And of course, remember to ask for thyroid function tests. And beyond these initial tests, depending on the setting, if you were in the celiac belt of India, which is clustered Delhi, Uttar Pradesh, Haryana, Punjab, then you would include IgA anti-TTG as initial testing. Again, remember that partial or complete selective IgA deficiency occurs in a small proportion of the normal population. So if the anti-TTG is negative and you still think that this person may have celiac disease, you will need to get an IgA level. In patients where you're suspecting hypogammaglobulinemia, you'll ask for the whole serum immunoglobulins. And sometimes you'll do a serum protein electrophoresis to look for what is called alpha heavy chain disease or immunoproliferative small intestinal disease. Now, there you will find that the alpha 2 globulins are elevated. And immunofixation electrophoresis, if there's a paraproteinemia. Chromogranin A is something that we will get done in anybody with a kind of suspected secretory diarrhea. The stool analysis is very important. So check for occult blood either using regular tests or fecal immunochemical test. And if it is present, it indicates that there is ulceration. Of course, it's commonly in patients without chronic diarrhea, it's also used to indicate neoplasia. If the WBC count is increased in the stool, then it indicates inflammation. If the pH is low, it indicates malabsorption. That's because carbohydrates get malabsorbed and get fermented, and that lowers the fecal pH. And then you can do a Sudan stain. So Sudan 3 or Sudan 4 can be added to a wet mount of stool and look at the size and number of the fat globules. And as you'll see in the panel on the right, if there are large fat globules, this indicates probably pancreatic exocrine insufficiency or small intestinal mucosal disease. You need to do a stool examination for parasites. These are the typical stool examinations where when you look for parasites, you do the concentration techniques, flotation and sedimentation. And you can pick up these helminths. And here on the right is a Strongyloides stercoralis. On the left is a Capillaria philippinensis. Now, these are the two helminths that can cause chronic diarrhea and malabsorption and protein losing enteropathy. So when you're thinking of worms that can cause diarrhea, think about these two. Apart from the helminths, the protozoa can cause chronic diarrhea. Giardia trophozoites can easily be found in stool if you just do a wet mount. But for the other ones, the ones listed below Giardia, Cryptosporidium, Isospora belli, and Cyclospora cayetanensis, require special stains to diagnose them. And the stains which are needed for these I've listed at the bottom. These are the modified acid-fast stain, which is the one which is widely used, safranine methylene blue stain, and trichrome stain. Now, ideally, it's best to identify these parasites by examining the stool. Now there are molecular tests which are available. There are molecular parasite panels. There are molecular microbial panels which will identify a lot of parasites and bacteria and viruses. Now, the bacteria and viruses are mostly useful in patients with an acute gastroenteritis and not so much in patients with chronic diarrhea. Now, microsporidia can also be picked up by these stains. They were originally thought to be coccidian parasites. Coccidian parasites are protozoa which live inside the epithelial cells of the small intestine. So Cryptosporidium, Isospora, Cyclospora are in the epithelium. Now, microsporidia have recently been reclassified as fungi, and there are two species, enterocytozoon, which responds to albendazole, and encephalitozoon, which responds to nitrous oxide. So these are examples of stool with the modified AFB stain. On the top, you have Cryptosporidium, which is about 5 micron sized. Just below that, the one with the two kind of nuclei which you see is Isospora belly, which is about 30 microns in diameter. And the right-hand lower panel is microsporidia. You can see why it's called microsporidia. They're very small. And then there are special tests that you would do in stool. So calprotectin, which is increased in inflammation. Fecal elastase, which is reduced in pancreatic insufficiency. And sodium, potassium, and osmolarity, which in patients with secretory diarrhea, when you don't get immediately a diagnosis through your usual tests, and you need to know that it is actually a secretory diarrhea, not an osmotic diarrhea, you will get to do the sodium, potassium, and osmolarity. I'll talk about this a bit later. And then we come to imaging. So once you've done the blood tests and the stool tests, these are the general ones, and then you go on to imaging. This is this is nowadays, I mean, we've kind of transitioned from barium meal follow through to CT scans, which are now done everywhere. And typically, CT scans in the periphery are done with positive oral contrast, which is shown here. So in positive oral contrast, if you see the loops towards the top half of the slide, they are all opacified with oral contrast. In the bottom half, the small bowel loops are enlarged. They are, they are packing the pelvis, but and you see that the contrast hasn't reached the lower end. And this is also typical of malabsorption. This is another feature typical of malabsorption when there's progressive dilution of contrast as you go lower down in the small intestine. And when you see a whole lot of gas in the small intestine, then that's again suggestive of malabsorption. This is probably inflammatory bowel disease. You're all, I'm sure, familiar with the comb sign, which you see here in the left side of the panel. Nowadays, we actually do CT enterography, and this is what is recommended, where you use negative oral contrast. And this is from a patient with eosinophilic gastroenteritis, which is another common condition that we see nowadays as the cause of chronic diarrhea and malabsorption. And here you see in the left side of the panel, you see the jejunum showing mucosal enhancement, and then there's a lucent layer beneath the mucosa, and then there's again an enhancement. And this is, and also this patient had a little bit of ascites, so eosinophilic gastroenteritis, which can affect both the mucosa and the serosa. So it gives rise to combination of these findings. So there is, maybe at this point we'll stop, and can I request the team to have a break here. We'll have the poll questions, and then I'll go with the rest of it.
Sure.
I think this is absolutely wonderful, sir. Dr. Dixit, want to take some questions? And let me also ask all the people who are watching this masterclass, please do write questions, and we have very good questions on the chat box. Let me start one question which is asked by Satya Balan, that what are the common causes of chronic diarrhea in southern part of India?
So there's actually a poll, but that's fine.
Okay. So we'll take this as the poll. So we'll drop this question at this point of time.
No, so we can have that. So in the southern part. So I guess
Yes. So let's look at this poll. And the tech team, can we show this? Raise the poll, and please do respond to this question. Can you start the poll?
Yes, sir.
Yes, please do that. How much time we have for poll?
I think we can stop it now.
Okay, great. Perfect. We can stop the poll at this point of time. So what we
Perfect.
see that Dr. Ramakrishna.
Yeah, so I think it's right that across all areas of practice in the country, I'm sure IBS is probably the most common cause of chronic diarrhea, and that is why you have to separate functional diarrhea from organic diarrhea. But
Yeah.
then when we come to the others, again, it depends on where one practices. So probably in the cities, in the metropolises, IBD is very common. But I think if you go out to smaller towns, intestinal tuberculosis is not uncommon. Malabsorption syndrome is not uncommon. Parasite infestations are also not uncommon. Particularly if you go to smaller places and rural areas and lower socioeconomic strata.
Right. So one other question there from Dr. Sunil Kumar, and he writes that how to define frequency of diarrhea. To tell whether it's a high or low frequency, is a cutoff, and how do you define a cutoff for low volume versus high volume diarrhea?
All right. Okay, that's a good question. So the normal stool volume in Indians is assumed to be anywhere between 2 to 400 ml a day. I mean, it was originally measured in grams, and I'm just loosely translating it to ml. But so if you look at that, anything which falls within that range or below that range will be low volume, and actually it means that there's an increase in stool frequency, but the volume has not increased. When we say high volume diarrhea, we are talking typically of more than a liter a day.
Right. But also we know that the volume may also vary. It may be 1 liter for sure, but it could be even less. The other question is by Mahesh Rathore, that why are these disorders are affected by psychology of individual, like disorders of blood-brain interaction, while frequency is more in those patients who have a psychological disorders or psychiatric disorders.
Right. So that actually pertains to DGBI or irritable bowel syndrome, and why it occurs is there are many explanations involving the gut and the brain. There are also studies which suggest that association with overt psychiatric disorders is more in Western populations than in the Indian population.
True, right. True. The next question is by Avijit. What is asked that you said in your talk that it is not just the positivity of an organism in the stool examination, but the quantitation as well. But how do you quantify parasites in the stool?
So, so for many years, when we were in CMC Vellore, we've had community screening for pathogens. And so I'm talking of my experience in CMC Vellore, but the same is replicated worldwide. There's something called the GEM study, which was done internationally. And around the world or across the world, what you'll find is a lot of people will have parasites in the stool, they will have pathogens in the stool, but they will have no symptoms. So it is not only the presence of a parasite or a pathogen, but it's also the host response to that, which is what causes diarrhea. So just the mere presence on a say a biofire panel does not necessarily mean that that is causing the chronic diarrhea.
There is a question from Satyabalan. Any difference between the causes of the diarrhea in South Indian and the North Indian population?
There are differences. There are differences between the North Indian and South Indian population, but I think that some of them are exaggerated. For instance, celiac disease is clearly much higher in North India. Overt celiac disease is virtually uncommon, virtually unknown in South Indians. If you look at, say, IBD, ulcerative colitis would be much more common in North India, whereas Crohn's disease is overwhelmingly more common in South India.
And sir, how we can make this approach to diarrhea more simpler? This is a question posed by Dr. Arun.
All right.
Rather than going for so battery of tests, actually, how can we make more simpler the approach to a diarrhea?
So I'm sorry if I gave the impression that you need to do tests. I thought the emphasis was all along on clinical acumen and very simple tests. So I'm not even proposing. So in fact, all along, what I thought I said was that we should use only simple tests. But there is the second half of my talk coming, where I'll actually at
Yeah.
the end I'll give an algorithm, and people can see how it fits into that.
Okay.
Exactly. I think that's very well said, sir. I think the approach to chronic diarrhea is all about history. How well you take history, and what Dr. Ramakrishna showed 7 or 8 points: small intestine, large intestine, pain, no pain, blood, no blood, inflammation, no inflammation, and volume of stool. All of these points, if you put them together, along with the features of malabsorption, which Dr. Ramakrishna suggested, if put them all them together, I think we can understand where is the disease, what is the pathophysiological reason for this disease. Uh, uh, Dixit, do we go to now to the second half
Yeah.
of the talk and we come back
Yes.
for
Okay.
more discussion?
Sure. Sure, sir.
And if I can
But
share.
I must say the questions in the poll are fantastic, very, very
Yeah.
interesting,
There are
and
many
very
more actually.
useful. Absolutely.
Yeah.
So, can I start? Can I share my
Yes.
Yeah.
screen?
Okay, sir.
Okay. Okay, we were at this point, and I'll proceed to the next. So after imaging, being gastroenterologists, clearly we do endoscopy. And here you see on the upper left panel, which is B, you see the typical scalloping, which is indicative of mucosal atrophy in the duodenum. Now, I'm not going to show you endoscopic images of the colon or enteroscopic images because they actually, a lot of them have to do more with inflammatory bowel disease. And I'm not going to focus on IBD here. It's there. It's a cause of chronic diarrhea. We know how to diagnose it, and it'll be dealt with, I'm pretty sure, in another masterclass. But let's go on to biopsy of the small intestine. Now, when you think clinically that you've diagnosed small bowel diarrhea, it is absolutely imperative to take a small bowel biopsy. And because there are a whole lot of disorders that can be diagnosed by small bowel biopsy. And these include celiac disease, tropical sprue, lymphoma or IPSID, Crohn's disease, TB, parasitic diseases, eosinophilic enteritis, collagenous enteritis, hypergammaglobulinemia, where you find a paucity of plasma cells in the lamina propria. The lamina propria will look very hypocellular. Whipple's disease, lymphangiectasia, etc. I'll just show you a few examples. So in tropical sprue, what you see is that the villi, which are seen here, and the crypts, here you see a villus shortening, crypt elongation, so that the ratio is about 1:1, and there's an inflammatory infiltrate in the lamina propria. Sprue is a diagnosis exclusion. I mean, you can show villus atrophy, but you have to exclude other causes of small bowel malabsorption. Now, then going on to something like this, which is total villus atrophy. So this almost looks like a colonic biopsy. You see that the small bowel villi are absolutely flat, the crypts are elongated, and this is very typically seen in celiac disease, but you may also get it in IgA deficiency with a flat mucosa. Now, primary immunodeficiencies are I think this sorry, this was meant to be not no therapy. I'm only emphasizing the approach. So we're just looking at small bowel biopsies here, and here's a biopsy. It all depends on how the pathologist, how intently he or she looks at the biopsy. And here you see giardia sticking to the surface of the small bowel. You can see the epithelium and a few giardia, typical giardia there. This is cryptosporidia sticking to the epithelium again, and can all be seen on light microscopy. And this is a patient that we had who had cyclospora. The left-hand panel shows a kind of lower power view of the small bowel. And in the right-hand panel, you can see within the epithelial cell, you can see the basal, you can see the typical tall epithelial cell, basal nuclei there. And in one of these epithelial cells, in fact, two of them, you can see something like a cluster of bananas. So it is, it all depends on the interest that the pathologist takes to diagnose this, because this can easily be missed if somebody just randomly looks at it and says, oh, there's nothing much here. Lymphoma, basically what it shows here is that the villi are very blunted, they are broadened, the crypts are effaced. So effacement of crypts by the lymphoplasmacytic infiltrate is indicative of a lymphoma. This happens in immunoproliferative small intestinal disease. The right side panel, basically it shows immunohistochemistry for CD20, the marker for this. This is intestinal lymphangiectasia, easy to diagnose because the huge lymphatic channels. This is a condition which is very often overlooked. So this is a patient who could be diagnosed as celiac disease, but it's not celiac disease. You can see that there is a total villus atrophy, and you see the endoscopy showing the scalloping. This person actually has olmesartan enteropathy. And olmesartan enteropathy is slightly different from celiac disease because they also have abdominal pain. I'm not sure why they have abdominal pain, but that seems to be characteristic. Otherwise, normally in celiac disease, unless there's a complication, you don't expect to see the patient to have abdominal pain. There are other causes of chronic diarrhea like microscopic colitis, collagenous enteritis, factitious diarrhea, bile acid diarrhea, idiopathic secretory diarrhea, and drug-induced diarrhea. So we'll just quickly go through some of these. Bile acid diarrhea is widely considered in the West. Here also it is there. Maybe it is responsible for about 5% of our patients that chronic diarrhea. Type 1 is due to ileal resection or disease, like Crohn's disease. Type 2 is idiopathic or primary. Type 3 is secondary to surgery, post-cholecystectomy, post-vagotomy, SIBO, etc. So the test for this is not available in India and not available in the US either. It's called the CCAT test, selenium homotorocolic acid test. So if you give this and the person has less than 15% remaining in the body on day 7, it is abnormal. That means the person is losing bile, as in the stool. So serum levels of C4 is another test which is used for bile acid diarrhea. Also serum fibroblast growth factor 19, which is inversely correlated with C4. There are a number of drugs that can cause chronic diarrhea, and remember to inquire about all of these. So antacids, antibiotics, anti-neoplastic chemotherapy, immune suppressants like mycophenolate, lenalidomide, bortezomib, NSAIDs, and antidiabetics. And of course, all of you are familiar with antidiabetics and the diabetic diarrhea. Pancreatic endocrine tumors are other causes of chronic diarrhea. So here you measure stool weight and water and calculate osmotic gap. This is what we used to do. Now it's become much more simpler because you do a chromogranin A, which is elevated, then you evaluate further. You can do plasma peptides can do urine tests, and also for some endocrine tumors, think of thyrotoxicosis as well. So this is a recent a paper this gives an American perspective. This is in the Journal of Clinical Gastroenterology 2 years ago. The issue is that it's all of this chronic diarrhea is based on where you live and what is most common. You go for the diagnosis according to that. So here, this person suggested that watery diarrhea, look for carbohydrate malabsorption, celiac disease, osmotic laxatives, bile acid malabsorption, etc., endocrinopathies, medication, functional diarrhea. And if it's fatty or greasy, there's another list which we've already talked about. And if it's inflammatory, things like infections, Campylobacter can be something that can go on for a long time. Clostridium difficile, of course. Invasive bacterial and parasitic infections. Amoebiasis can go on for some time if it is not recognized. Ischemic and radiation colitis, lymphoma. And the other entity which we do see sometimes, which is colonic diverticulosis associated with segmental colitis, also called SCAD. Now, let me just share with you the picture of somebody which was brought to me by one of my patients. So his young son was having diarrhea, and this is the watery diarrhea that this boy was having. And he's recorded it and made a video of it. Now, this boy, unfortunately, underwent a lot of investigation. He had 2 colonoscopies. He had enterographies, and he was being treated as inflammatory bowel disease with budesonide. Now, his father brought this picture to me, and what it immediately suggests is that this is factitious diarrhea, that this is not true diarrhea. This boy has managed to get water into his colon, and he is bringing it out. And so surely enough, we did the stool characteristics. You look at stool osmolarity here to 74. Stool sodium was 11. Stool potassium was less than 2. That was the values. Now, remember that stool osmolarity is usually close to plasma osmolarity. Usually it is around 280. So here in secretory diarrhea, you expect stool osmolarity to be 280, and you expect the product of sodium plus potassium into 2 to be close to the 280. So that is secretory diarrhea where there's a low osmotic gap. And in between, I've shown you what happens in osmotic diarrhea where the stool osmolarity is increased. And stool sodium and potassium into 2 is much less than the osmolarity. So this boy actually had factitious diarrhea. So it's very important to listen to your patients, to take a good history, and when possible, look at the stool. So we encourage all our patients to bring photographs of their stool. And in this case, the patient's father actually made a video, which is very useful when we tried to assess what the problem was. So the BSG guidelines 2018, investigation of chronic diarrhea, this is what they suggest. Remember what I said? So it all depends on which part of the world you live. So here they say fecal calprotectin in patients under 40. They suggest a fecal elastase, a fecal immunochemical test, dual testing for C. difficile toxins, a CCAT test, or a fasting C4, that is 7-alpha hydroxy 4-cholesterol 3-one, which is indicative of a bile acid diarrhea. And then they say trial of bile acid sequestrants. And this is something that we do sometimes in our patients, in our older patients with chronic watery diarrhea, where you're not able to find what the cause is, that we actually give them cholestyramine and see if you give it, they will have a fairly dramatic response if it is bile acid diarrhea. And then they suggest hydrogen PET testing for lactose intolerance and MR enteroclysis. Additional tests which are used in research settings, basically things like lactulose mannitol ratio, which tells you about permeability and mucosal surface area, plasma citrulline, fecal lactoferrin, which tells you about inflammation, also neopterin. And the last two are 48-hour fecal bile acid assay and serum FGS19, which is advocated by the AGA for bile acid diarrhea. So this is an algorithm that we can use in patients with chronic diarrhea. And so this is many years ago with the ISG, and I'm sure Dr. Govind remembers this, that we created this algorithm. So basically, what is most important is clinical evaluation, basic blood tests, and a stool examination. So stool examination also for parasites and occult blood. So rule out factitious diarrhea, that is number one. So if this initial blood tests and stool examination and clinical examination tell you that it is functional, the person is normal nutrition, don't investigate further, at least not in the first instance. So if the clinical evaluation, you find it is fatty diarrhea, and sometimes maybe if it is non-bloody diarrhea, you do tests of absorption. The only test of absorption which probably can be still used is D-xylose absorption. There's a 1 hour blood xylose which is available in some places. Dr. Uday was talking about breath hydrogen after giving oral D-xylose. So those are tests which are tests of absorption. Otherwise, we are forced to rely on conditions like serum iron, serum vitamin B12, serum folate to tell you that there is malnutrition, which indirectly you infer as malabsorption. And then you go with a barium meal or a CT enterography, mostly CT enterography now. If it looks like diffuse mucosal disease, then we go with small bowel biopsy, IgA, anti-TTG, breath hydrogen testing, HIV, immunoglobulins, evaluate the pancreas. And as you progress further down, enteroscopy. If there is focal disease, if you find disease only in a particular area, then it makes sense to go with enteroscopic or open biopsy. If the person has watery diarrhea, which is not relieved by fasting, and if there's a low osmotic gap, then you straight away look for causes of secretory diarrhea. You can do a contrast CT of the abdomen, CT enterography perhaps, a chromogranin A gut hormone profile. If the chromogranin A is high, then we go with a Doter-Knock or a Doter-Tate scan. You would also try to screen for laxative abuse. If available, you can do bile acid tests, CCAT. And if it is not small bowel, then you still have to think of colonic causes of watery diarrhea, which would be microscopic colitis. So you'll need a colonoscopy and biopsies. If the diarrhea is bloody diarrhea, then look for trophozoites of E. histolytica. I've seen patients with more than a month of diarrhea, maybe even up to 2 months, still having amoebiasis. So never ignore that. Stool culture for Campylobacter, assay for C. difficile toxins, and sigmoidoscopy or colonoscopy and biopsy. So the approach to diagnosis is consider common causes first, take a good history that's essential. Physical findings may contribute to the diagnosis. Do simple blood tests, blood counts, ESR, CRP, AG ratio, stool examination, because I think these are really what are important. And then when you investigate, histopathology is more important than just endoscopy and imaging. And with that, I'll stop. Thank you.
Thank you, sir, for a very nice talk and elaborate approach to chronic diarrhea. I think there are many more questions actually we can see on the chat box. Somebody asked us what the minimum test of the bile acid to diagnose the bile acid diarrhea in the Indian setup, because those costly tests of CCAT or whatever you told. So what minimum test is required to diagnose the bile acid diarrhea in Indian setup? Somebody asked.
The minimum test is actually a therapeutic trial with a bile acid sequestering agent given for a week.
Sir,
If I can add,
well,
Dr.
my
Dixit,
personal, yeah,
Yes, Dr. Govind.
there's one test now getting not available, but being looked at,
okay,
the stool bile acid. So
I
in a
see.
liquid stool, you measure bile acid by chemical reaction. Again, this test
Yeah,
is under investigation, is not available, but has a lot of potential
I,
because you can
I
tell
actually
us,
mentioned that the AGA
yes,
recommends a 48-hour fecal bile acid test.
yes. So fecal bile acid test is done by HPLC, but
Yeah.
again, HPLC is difficult to do. But this is an ELISA-based test, which is under investigation, still not available. But if those comparative diagnostic accuracy with a stool, 24-hour stool or 48-hour stool HPLC based assessment of bile acid, then this could be a very good test. Yes.
okay. Sir, there was a question by Dr. Utmani, ki if a patient who has got a chronic watery diarrhea with normal colonoscopy and negative stool culture, then how we can differentiate between a microscopic colitis, bile acid diarrhea, and functional diarrhea? With a normal colonoscopy with negative stool culture in a patient with a chronic diarrhea.
So when you
So,
do,
is there any way to differentiate easily
yeah,
microscopic colitis versus bile acid diarrhea and functional diarrhea?
yes. So when you do a colonoscopy in a patient with chronic diarrhea, please do take biopsies from the ileum and segmentally from the colon. That is essential because
Yeah.
microscopic colitis can only be diagnosed by histology. So that's
Okay.
number one. So if that was normal, if biopsy was normal, then, and if you suspect bile acid diarrhea, then you'll need a therapeutic trial with the
Yeah.
sequestration. And if both are negative, then you're left with only with functional diarrhea.
Okay. Sir, just for my curiosity, sir, what still we are having the tropical sprue as a one of the important cause for the chronic diarrhea, as used to have in the south when we were the DM student. Because in North India, we don't see very frequently this disease, tropical sprue. So, what is your thought about this, sir?
So it's definitely not as common as we used to see, as you said, when we were postgraduates. But if you look at whatever series have been published from India, which is evidence,
Yeah.
it says that other than from Delhi, where celiac disease
Yes.
is most the same, you'll still find about 30% of malabsorption is tropical sprue. Interestingly, I've seen two patients of Indian origin from northern Australia who
I
were
see.
diagnosed there as celiac disease. They actually had, it was diagnosed there as pancreatic insufficiency. Actually, they had tropical sprue. In tropical sprue, what happens is you get a low fecal elastase. That is because there is not enough stimulation of the pancreas by CCK-PZ. And so you're not putting out, so there's a secondary pancreatic insufficiency. And so they were mistakenly
I,
diagnosed as PEI.
yeah. Dr. Makaria, please.
So I think a couple of more questions which are really interesting. The question by Dr. Pramod Reddy, that he asked that if you do endoscopy and do biopsies, then how many biopsies you take from duodenum, and which part, D1 and D2? And even D2, what is the ideal site for biopsy?
So so ideally, I guess we would take 4 biopsies from each site, and I would take from D1, D2, and duodenum, at least just beyond the DJ flexure, if it was possible, ideally. Sometimes there are issues with finance, the thing, etc. And some people are so very often in practice we see that fewer biopsies may be taken. Dr. Govind also wanted me to emphasize it. So we have a document on how intestinal biopsy should ideally be processed. So orientation of the biopsy is important in interpretation. There's an issue of whether the orientation should be done by the endoscopist or by the technician when they are actually processing the biopsies.
Right. I think it's very important. The biopsy, I think this is one of the ignored part of biopsy in small intestine. For small intestinal disorders, biopsy is very important, as Dr. Ramakrishna suggested. And once you do biopsy, orientation is very, very important. In relation, the same question comes that unless we tell pathologist that what I'm looking for, am I looking for, say, A beta, or I'm looking for lymphatic blockade disorders, or I'm looking at mucosal epithelial disorders, or something like that. Is it good to inform pathologists on the form? Because the only way we communicate with our pathologists and radiologists through our prescription or a form, especially in a academic institution, you fill a form and write clinical details. So what do you suggest, Dr. Ramakrishna?
Yeah, absolutely. I think we, at least where I am, we all our residents know that all relevant clinical information should be provided on the form, because that definitely helps. And I think close interaction, both with radiology and with pathology, it's very important because rather than blindly looking at something and you come with something, when they interact with us and know what we're looking for, they look more deeply.
Absolutely. And in related question, that's if what would be the indication of doing a CT scan or CT enterography or MR enterography in those patients who come with chronic diarrhea?
So it still follows the standard algorithm. I think if we have excluded functional diarrhea, I think that's we saw that 20 out of 24 or 25 responses said IBS is the most common. So clearly you don't want to do CT enterography in them. So the most important thing is to exclude functional diarrhea. Once you've done that, and your blood tests and the initial simple tests give you a clue, and your clinical this thing tells you where it is. Is it small bowel or is it large bowel? If it is large bowel, then probably straight away probably do go to a colonoscopy and biopsies. If it is small bowel, or if you excluded large bowel, then we'll go and think about imaging. And imaging, typically nowadays we prefer CT enterography. CT enterography uses negative contrast or neutral contrast. And what you find is you can find mucosal defect because there is mucosal hyperemia. Normally the mucosa enhances in the initial stage as the contrast is injected. And so that you get a very nice picture of the mucosa if they've done it properly.
The question by Dr. Jayanti, I think Dr. Jayanti Venkataraman is the very senior gastroenterologist. I think we say this is our teacher. She's our teacher. She asked a question that what do you say to all our postgraduates and all our gastroenterologists in our country and elsewhere, that how do you differentiate those patients who have chronic diarrhea and those who have malabsorption in addition?
So the question, how do you differentiate chronic diarrhea due to malabsorption?
Yes, and those without.
So again, this goes back to clinical examination, goes back to history taking. So I said if there are features of carbohydrate malabsorption, there's borborygmy, there's bloating, there's gas in the stool. If there's fat malabsorption, if there's steatorrhea, so these are indicative of small bowel disorders. If there is pain, which is periumbilical, it is still indicative of small bowel disorder. In malabsorption, which is not inflammatory, you will not have pain. So for instance, in a person with tropical sprue, there is no pain. In a person with celiac disease, there is no pain unless they are developing ulcerative jejunoileitis or they are developing a lymphoma. So these are clinical clues which are essential. That's why I said, I can sit in my chair with the patient across the table, and without ever examining the patient, I can very often come to a diagnosis. I think we need to spend time with the patient to understand these things. So that is a message that I will give to all our postgraduates, because that is something in the hurry of modern practice. I think very often this is forgotten, that you need to get these details from the history.
And Dr. Ramakrishna, you made a so important point that in disorders like malabsorption or chronic diarrhea, the true conversation with patient is so important. And also I want on this topic, since it's very important that the interaction with patient, maybe also ask Dr. Dikshit to comment on this, that how important it is, and also to the Ghosal, that to re-emphasize one more time that conversation on this topic is so important, because the disease cannot be seen by CT scan or ultrasound or any blood tests. It's all about compilation of your clinical history that will give a pathway. And that's very, very important in approaching patients with chronic diarrhea. Unlike those patients who come with ascites, bleeding, and has encephalopathy, it's absolutely clear this patient had chronic liver disease. But patient will come with chronic diarrhea, you don't have many more clue. And therefore, unless you ask more questions and examine the patient well, it will be like doing upper GI, lower GI, keep doing tests and go round and round and still don't reach diagnosis. It may still happen, but doing a approach which Dr. Ramakrishna suggested, that goes systematic, it will be much easier to reach to a diagnosis with a minimum use of tests. Dr. Dikshit?
Yeah, I fully agree with Dr. Govind, because it is such a common problem in day-to-day practice. Actually, um, we have to actually know the actually right approach to. I think what Dr. Ramakrishna has highlighted, you take a just see once you receive a patient with chronic diarrhea, you just find is it a chronic diarrhea. Uh, do you think it is so? History taking is the most important, because history can give you many things. It can tell you whether you are dealing with the functional diarrhea or whether you are dealing with the organic diarrhea. So history taking is very important. And once you make a clinical diagnosis, whether you are doing small bowel diarrhea of organic or functional, then you just give some battery of tests, very simple tests. Like simple stool examination is very important. Sometimes even inspection of the stool itself is, which is we actually forget to see this thing. Our residents also they hardly see. Otherwise, we were TM student, we have to nakedly expect the stool actually. And by stool, seeing the stool, you can make a diagnosis whether the patient has got malabsorption or a patient has got steatorrhea and all that. So that's why good history, then physical examination. Some of the very important positive finding will tell you you are dealing with the organic disease or something, and then you do some simple tests like stool examination test, stool culture, and then you do simple sigmoidoscopy or upper GI endoscopy, depending upon that. And before that, you can, if you find patient has got a typical malabsorption, then you do some initially non-invasive test, do stool like elastase, etc. And the biopsy remains one of the most important. So it should be done actually as far as possible to before you make a final diagnosis of malabsorption. So I think that though it is invasive, but that is the gold standard actually to diagnose the organic disease leading to malabsorption.
If Dr. Uday is there, or we go to one question, which is, I think, is very relevant, which is asked by Dr. Devashish Sarkar, that parasitic diarrhea caused by parasites is decreasing actually, and that may be true, but or it is because of decreased incidence of parasitic infection, or because of poor quality testing. Poor quality testing. We don't test well.
That's a good question. So I think so. One of the issues with this, I talked about some coccidian parasites, which are basically protozoan parasites which live in the epithelium of the small bowel. And these coccidian parasites, if you want to identify them on stool examination, you have to do special stains for them. They are not visible or detectable on the normal stool examination. So that's something that many people don't appreciate. And a standard laboratory stool analysis, stool routine analysis will not pick up many of these. So in fact, conditions like cyclospora were originally picked up in Nepal as a cause of diarrhea, essentially because somebody probed it and looked further to see what. And that's something that needs to be incorporated.
The two questions are related. At first, that somebody had a cholecystectomy, and now 5 years down the line, he or she comes with diarrhea. This is question by Pradeep Satya. I mean, post 5 years down the line, post cholecystectomy, person develop diarrhea.
So the question is it related to the cholecystectomy at all? Is number one. So again, you'll have to go back to the history and see what are the other characteristics of diarrhea and the duration. If they've come to you within, say, 5 weeks of starting diarrhea, then I think you have to rule out other causes. So you cannot, 5 years after a cholecystectomy, you're not going to blindly say that this is a post-cholecystectomy diarrhea. It would depend on your clinical history, just like anybody else with chronic diarrhea. The cholecystectomy is incidental. It could be the cause, but you're going to come to it later.
Can I raise one question and ask you that small intestine, also large intestine, have a large surface area. If somebody has either tropical flu or celiac disease or microspheculitis in large intestine, the symptom generation will take a lot of time because all the organs have a huge amount of reserve. So most of these patients remain undetected or remain asymptomatic to start with. And when symptoms appear, the disease is quite advanced. What are your point of view on this? Number one, and what could be the methods that we can detect disease early?
So small intestine, like I said, I mean, it's the area is surface area is equivalent, say, to a football field or a tennis field, a tennis court. So it does. You can have reduction in the surface area. You can have reduction in small intestinal function without it become clinically apparent. If it is not clinically apparent, it is going to have different kinds of consequences. They may not present with diarrhea. And this happens probably, for instance, in celiac disease, where they can present with anemia, they can present with metabolic bone disease, they can present with infertility rather than with diarrhea. So maybe it's a subclinical kind of presentation there. So the only way is that if you have some kind of other, if they're asymptomatic, they're not going to come to you.
Absolutely.
So we have to be aware of these other kinds of presentations and then atypical presentations and then go in to look for that.
Absolutely. It's like akin like the next.
Okay, so there was also question: is that a patient who has got 5 years post colostomy down the line develops the diarrhea? What do you think the most likely mechanism for that?
Yes,
patient having post colostomy, and now after 5 years they come with a chronic diarrhea.
So I was trying to say that most likely it is not related to cholecystectomy, because post cholecystectomy diarrhea generally occurs very rapidly after cholecystectomy.
Yeah. So in your experience, how many cases you see commonly it's about the IPSIT causing a diarrhea, like intestinal lymphoma you discussed earlier? So because we hardly see, actually, hardly once in 2 or 3 years I must have seen. Otherwise, it's very uncommon. Though we discussed it as one of the differential diagnosis. So what is your experience about the IPSIT?
We used to see it more often. It is very uncommon now. So SID has been related to chronic immune stimulation during childhood. And so it happens in people coming from a very low socioeconomic background who are exposed to a lot of intestinal infections in childhood. And that's maybe one reason, maybe why we are not seeing it so commonly now. Not that it was common, it was rare in the past, but we used to see a few. Now you see it occasionally.
Yeah. And when you suspect the antibiotic-associated diarrhea, what's the characteristic of the typical antibiotic-associated diarrhea? When we suspect, and what minimum test is required to confirm yes, you are dealing with the antibiotic-associated diarrhea?
Okay. So antibiotic-associated diarrhea, there is antibiotic-associated diarrhea, and then there is Clostridium difficile-associated diarrhea or disease. So C. difficile occurs as a consequence of antibiotic use, but there is also plain antibiotic-associated diarrhea which can happen with antibiotics like amoxicillin, ampicillin, and so on. But C. difficile is something that we need to check. So there's a rapid test available, and the test is kind of similar to the rapid antigen test which you use for COVID. So it allows you to test for toxins A, B, and for GDH. And the result is available very quickly. So the thing is, it needs to be done on a liquid sample of stool, and it needs to be done processed immediately. If you don't, you may get false negative tests. To confirm this, ideally, you should do PCR, ideally.
Yeah.
Dr. Ramak, let me ask one question. Your personal experiences that the approach you described and you taught us in your own practice, if you use this approach of 100 patients comes to you say, over the next 3 months, in how many you are confident that you are able to make a diagnosis?
If I use this in 100 patients, how many am I making a diagnosis?
I mean, you're right. Your approach is more or less in order.
So I would say 95%.
I totally agree with this. I totally agree with this. But approaching, I think, of all GI disorders, this kind of algorithm is very important. And if you use this algorithm in a systematic manner, in majority of time, one is able to say this is a small intestine, this is a mucosal, this is a non-bile absorptive, this is a large intestinal, this is a large intestinal ulcerative, or large intestinal non-ulcerative like multiple colitis, and one is able to make a diagnosis. So it's good to practice this proper algorithm, which is all based on historical aspect. Before we close, a couple of more questions. Number one is it's very important for those patients who have diabetes, and there are a couple of questions on our chat box also, that in those patients who are diabetic and they come with chronic diarrhea, there are many causes described, and I think we know theoretically what could be possible cause. The drug also a cause for chronic diarrhea in such patients?
Drugs cause chronic diarrhea with diabetes, most certainly. So those are things that we need to be aware of, and there's a list available when it's available, we have them. Metformin is obviously the most common offender, and but the others also can. And so if you really strongly suspect it's drug-induced, you need to stop that and see, or substitute something else. Obviously, you can always go on to insulin and then stop those medicines and see. But in diabetic diarrhea itself, then it can be due to problems with motility, it can be due to problems with fluid transport, or it can be due to bacterial overgrowth. And then each of those will have to be tackled appropriately.
There is a question.
Yeah.
Okay.
Dixit.
Go ahead.
Yeah. No, please go ahead. Please go ahead, Dixit.
No, somebody asked that what is the role of FMT in the intractable chronic diarrheas?
None.
Idiopathic chronic diarrhea.
No
Any
role.
role of the FMT?
No role to the best of my knowledge.
Yes, Dr. Makaria, please.
So again, coming to other question, which is again fundamental question, that increased frequency of stool, but normal consistency.
So typically we would say that that is due to functional bowel disorder. But there are conditions with rapid transport that, like, for instance, you might get an hyperthyroidism, and then some other conditions where or due to drugs, where you can find normal stool with still chronic diarrhea.
And maybe this could be a last question, again fundamental question, that in clinic, how do I differentiate a patient having osmotic type of diarrhea or secretory type of diarrhea? And this is a question which is asked by 3 persons. I think this is very important. Yeah.
So osmotic diarrhea. So typically, if the patient fasts, if there is no diarrhea, that is osmotic diarrhea. So see, osmotic diarrhea can be due to malabsorption, like in celiac disease or sprue, or it can be due to taking in some osmotic things, like I talked about chewing gum with artificial sweeteners like sorbitol and so on. So there, if you stop your food intake and the diarrhea reduces, then clinically that is osmotic diarrhea. Secretory diarrhea, the only thing is that the stool tends to be very watery. So osmotic diarrhea, if it is not due to taking sorbitol or lactulose, it will be mushy at least, because there will be some fecal matter in it, and that's what is causing the osmotic part. So that will be additional criteria to differentiate clinically.
And as you said, fasting, I think people have misconceptions. Some people have misconceptions that a patient fasted for 1 day and there's no diarrhea. So, I mean, for normal people, the 1 frequency per day, maybe 2 per day. So, the transit is not such that a patient will fast for 1 day. No diarrhea does not mean it's not osmotic or it's not secretory. It has to be a test called 48 hours. In 48 hours of fasting, which is a test which is not a normal experience. Like many of our family, mothers, sisters, our they do fasting for 1 day. The fast with religious fasting. Also during Ramadan, most of our Muslim friends do fasting for 24 hours. So not 24 hours, 16 to 18 hours. That's not fasting test for secondary diarrhea. It has to be for 2 days, 48 hours. And then at 48 hours, there's no diarrhea, then you might say it's not osmotic, it might be secretory. But let's not go by that missing 1 meal is fasting for this test. I think with that, Dr. Dixit, you have a last comment?
Yeah. But what I can say, there are many more questions actually left, but that shows the popularity of the process. We are Ramakrishna. He has taken a masterly, really, the topic, how to approach the patient with the diarrhea, what the minimum test required to do that, to make a diagnosis, and then how we can manage. He has very elaborately discussed it, in typically algorithmic approach, and the newer tests also he has highlighted. I think this must have definitely benefited our postgraduates whenever they see the patient in their OPD, other things that will help them actually to crystallize more clearly what they are dealing with and how minimum test is required to make a diagnosis in the patient with the chronic diarrhea. So this will be very useful for not for all of us, for the PGs particularly, because they are going to see the patient in the daily OPD and taking the exam. So I must really thank from my heart and on behalf of the IC to Dr. B.S. Ramakrishna for taking the pain actually and taking time off to take this master class on a very common subject, which we see. I think this is one of the very common symptoms actually we see all gastroenterologists. They see in their OPD clinic. So thank you, Dr. B.S. Ramakrishna, on the behalf of the IG also, and I will request Dr. Makaria to make a last comment.
Dr. Ramakrishna, your last advice.
Thank you for the opportunity. I hope it was helpful, and I would agree. I would urge everybody to, really spend more time with patients in getting these details when you see someone with chronic diarrhea.
I think Dr. Ramakrishna, this has been a wonderful, again, master class for a common problem. What could be a clinical approach to reach a diagnosis? This is absolutely fantastic. I think we learn always, every time we learn from you, Dr. Ramakrishna, you have been a fantastic teacher to all of us, and your deliberation today have been really fantastic. With that, we'll like to thank all the participants, and there have been more than about 600 participants. That's a very encouraging, and we are so happy that masterclass had become popular, and we have a lot many of colleagues who joined the masterclass. So with that, I'd like to thank all the participants of this masterclass. Masterclass is a regular activity. We have a next talk on August 17 on, again, very important topic. I think it's very, very important topic. There's an approach to unexplained weight loss in GI practice. And this will be delivered by Dr. Amit Datta. Again, Amit Datta is a well-known gastroenterologist, a great teacher, a great scientist, and he's a professor at CMC Vellore. And we look forward to his talk on 17th of August. I'd like to thank the ISC for initiating this activity. I'd like to thank Nisa. Nisa is I think she's the person who helps and coordinates all the program of ISC. And I would say she's just simply fantastic. All the people who joined on the masterclass, I'd like to thank Dr. Uday Ghosal, the president of ISC, the Secretary General, Dr. Matthew Philip. Both have to leave because of a simultaneous program being happening in the Trivandrum, what we call GRIP, a program for physicians. I'd like to thank the tech team led by Dinesh Ji. And so we had a great day today. So with that, thank you so very much. Have a good day ahead. And we look forward to see you on August 17 for yet another masterclass. With that, thank you, Dr. Ramakrishna. Thank you, Dr. Dixit, for this discussion today. Thank you, everyone. Have a good day ahead.
Thank you,
Bye-bye. Bye-bye.
Thank you.